Good evening, everybody. First of all, I'd like to thank convener. My teachers are here, and I'll be talking about cataract with macular problem, what to do and when to do in cases of choroidal neovascular membranes. I'll skip the initial part, and I'll try to answer these four questions which is there in the mind of all anterior segment surgeons. First question is, does cataract surgery worsens choroidal neovascular membrane? The answer is big no. So what does the literature suggest? AREDS2 study, that is age-related eye disease study 2, mentions that the participants in the study were evaluated for up to 10 years, and after cataract surgery, a mean improvement of +4 and +11 letters in AREDS1 and AREDS2 studies were there. That means there was a significant cataract, and after doing cataract surgery, the vision improved. The participants who had cataract surgery showed no increase in risk of AMD progression versus those who did not. The same conclusion we derived in Marina and Anchor trial. And in one of other study, cataract surgery leads to vision improvement and does not appear to contribute to worsening of age-related macular degeneration. And there are ample number of literature available which says that cataract surgery does not worsen CNVM. The next question comes, when should you do cataract surgery? The surgeon should decide whether cataract is hampering the vision or not. If you have a central cataract, you should go ahead and operate this patient. If there is a dense nuclear sclerosis, it tends to decrease the contrast sensitivity. So these patients should be taken up for cataract surgery. Central cortical cataract should also be taken up for cataract surgery. But before cataract surgery, as my previous speaker, Raja, Dr. Ashish, everyone has mentioned that screening of OCT screening of macular disease with OCT is a must. And there was a study in which we have done OCT before, and the result of that study was the management of 107 patient out of 411 patient was modified. OCT finding which were either missed in 22.8% or underestimated in 3.2% by fundus bimicroscopy examination. So OCT is a must in these kind of cases. The third question comes, when should you do cataract surgery? If cataract with CNVM is diagnosed at presentation, first treat the CNVM with 3 loading dose. Once the lesion becomes dry, then you can go ahead and do the cataract surgery. Cataract surgery should be avoided within first 6 months of the treatment. If the lesion does not dry up, simultaneous cataract surgery with anti-VEGF can be planned. And what we do is we give anti-VEGF once we have inserted the IOL, and we don't do a viscoelastic wash and inject because the eye is hard at this moment. Once the injection is given, after that viscoelastic wash is done. The third question is, how does it helps the patient of age-related macular degeneration? The first thing is it increases the contrast sensitivity, thus helps in reading vision, also improves the BCVA and peripheral vision, thereby helping daily activity. It decreases glares and improves color vision, thus helps in the quality of life indices. In a recent study, identified the risk of fall, which decreased by 54% once the one eye was operated, and other eye, once the second eye was operated, the disease of fall was reduced to 73%. It improved the visual acuity and contrast sensitivity, and there was a decrease in number of falls. The fourth question which comes in mind, which IOL to choose? So unifocal or aspheric IOLs are the best in cases of wet AMD. Toric IOL do not compromise with contrast sensitivity and can be used in patients of age-related macular degeneration. Multifocal IOL should be avoided as it decreases contrast and has higher order aberrations. Evidence of EDOF IOLs are well tolerated in patients of AMD would be required before advocating them. So to conclude, cataract surgery does not worsen the AMD disease process. OCT scanning is a must before taking patients for surgery. Surgery should be done after 6 months of initiating the treatment. Simultaneously, cataract surgery and anti-VEGF can be considered. There is an improvement in BCVA and contrast sensitivity, which improves the quality of life, and multifocal IOLs should be avoided. Thank you very much for your kind attention.
Thanks, AVNINDRA. I think that was an important message that cataract surgery doesn't worsen ARMD disease. That means a good cataract surgeon, if you're given a injection, you don't have to wait for 3 months for it to dry up, or because the cataract surgeon says, jaldi karo, let's operate the cataract.
See, if it is diagnosed on onset, you should dry up the lesion and do the surgery after 6 months. That's what the literature recommends. If the patient is on a follow-up and is on treat and extend protocol, then...
But in your setup, if Mahipal is he wants to operate cataract.
No, that he doesn't. Because the problem is, the brunt will come, patient will come and tell I didn't get any benefit from cataract surgery. And then it will come to the retina surgeon, you manage.
So wait for 3 injections and dry up.
Wait for at least 3 loading doses and at least the macula to dry. And you should be able to counsel and convince the patient that yes, after doing cataract surgery, you will have a definite improvement in vision. Because after 6 to 8 injection, you develop a kind of relationship with the patient. And this relationship will help you to counsel the patient what time you should go in for cataract surgery. But the important thing here is, don't go for any premium IOLs, go for the basic unifocal IOLs.
How long do you wait before, when the CNVM has dried up, how long do you wait before you decide you can now safely go ahead and do the cataract surgery?
Sir, if I feel the cataract is enough and it will give a visual benefit in terms of contrast and vision, I'll go in for cataract surgery right away.
Thanks,
Especially in posterior subcapsular cataract, nuclear sclerosis, it benefits a lot.